everyone. Today I'm going to present on dot and blot hemorrhages. It's a very basic topic, but it's quite important. So I'll give the overview first. So we'll go through origin of dot and blot hemorrhages, then common causes and how to differentiate, and when to refer. So dot and blot hemorrhages, we all have seen, we all have read everywhere, but I'm going to go through some basics. So these are some dense dark red sharply outlined and are seen in disorders that affects the prevenular deep capillary layers. So what is the origin of it? So microaneurysms occur secondary to capillary wall outpouching due to the parasite loss. They appear as a small red dots in superficial retinal layers, and there is fibrin and red blood cell accumulation in microaneurysm lumen, and a rupture that produces blot or flame hemorrhages. So the position, if we see, dot and blot hemorrhages occur as a microaneurysm rupture in the deeper layers of retina, such as inner nuclear layer, outer plexiform layer, and this appears similar to microaneurysms. If they are small, fluorescent angiography may be needed to distinguish between the two. So intraretinal common disease and differentials, if we see, the location, size and distribution of the hemorrhage provides clues to etiology and uncover underlying systemic disorders such as vascular disease, hematologic disorders and dysplasias, infections, trauma or hypoxia. So if we see in diabetic retinopathy, dot and blot and vitreous hemorrhages can be seen. They are bilateral, diffusely distributed in the posterior pole. If we see in retinal vein occlusions, the diffuse intraretinal hemorrhages is seen in all quadrants in central retinal vein occlusion, and sectoral distribution is seen in branch vein occlusions. So here are the sins. Right side, if we see, it's a BRVO, on left side, if we see, it's a CRVO. So if we see in ocular ischemic syndrome, mid-peripheral intraretinal hemorrhages are seen. Mainly retinal neovascularization can also be seen in this. Sickle cell retinopathy, if we see, its intraretinal Salmon patches hemorrhages are there. Black sunburst, chorioretinal ischemic scars can be seen, and CFN neovascularization, which might lead to vitreous hemorrhage, and these are seen bilaterally. Juxtafoveal telangiectasia, so if we see in that, typically central dot and blot hemorrhages with chorioretinal scars and vitreomacular traction can be seen in that. So these are the basic things. And if we see differential according to the age group, in neonatal ages, hemorrhages may be from birth trauma, including the spontaneous vaginal delivery, vacuum extraction and double instrument deliveries. If we see in infant and children, it can be due to child abuse, Coats disease, persistent hyperplastic vitreous, retinopathy of prematurity, retinal dysplasia, hypertension, myopia. In systemic, if we see hematological or cardiovascular disorder, infection, protein C deficiency. In adults, if we see, it can be due to diabetes, hypertension, leukemia, blood dyscrasias, hypoxia, anoxia, high altitudinal syndromes, high myopia, posterior vitreous detachment, retinal tear, retinal detachments. So the treatment, if we see here, most of it requires a detailed systemic workup to detect the underlying cause of the hemorrhages. Management consists of observation, treating the primary cause, and intraocular management to reduce the ischemic and neovascular sequelae following the hemorrhages. Most dot and blot hemorrhages are not vision threatening and are usually found in the posterior pole, sparing the fovea, and can be observed. Hemorrhages seen in retinal vein occlusions are not treated per se, but the retinal edema and the neovascularization which follows the sequelae needs to be treated. So main take-home message, sometimes dot and blot hemorrhages can be just the tip of the iceberg. We need to investigate the ocular findings by OCT, OCTA or FFA. For blood investigation, if we might need to refer the patient to specialists like retina surgeon, physician, endocrinologist, pneumatologist, and timely referral can save the patient's vision. Thank you.